As Kayla said, I'm at Public Health Institute. I started there working on asthma programs, so I was with Regional Asthma Management Prevention Project, and then left that to work on PHI's Community Transformation Grant project, which is how I met Lorraine and Ron and Suzanne and others that maybe no longer are here. But and so my challenge in this was to think about what do you already know versus what would be new, and not knowing all of who would be in the room. So if there are questions, if I shortcut something and you're like, I have no idea what you're talking about, definitely ask me the question. I'll do my best to dust off those cobwebs. But just to try to talk about what we did then as a community transformation grant and what CA4Health is today, because we've retained the name, even though we're no longer doing community transformation grants. So that was the approach that I took here.
And are you going to tell us a little bit of the history of the funding of the CDC? Because some of this was, a lot of this was out of our control.
Yes, so that is,
okay, great.
That is here. So have folks heard of like the REACH grants that CDC did and does, the racial, ethnic, something, advancing community health, something like that. And when I was at RAMP, we had a REACH grant to be a center of excellence. And at that point, CDC had been doing REACH awards for a number of years and was really looking for a way to engage larger population groups. But a lot of the REACH grants were smaller, very defined. Even if successful, they weren't necessarily moving the dial on a large scale. So the data out there around disparities wasn't changing in any large fashion. And this caused a lot of uproar. I remember being at a CDC meeting and people were forming coalitions to try to get them to keep the REACH funding, but they went in this direction of the community transformation grants. And while I think what CDC was doing was trying to build on what they had learned, but also add in new elements that they wanted to see happen. And it was designed to be a 5-year grant from 2011 to 2016, but it wound up being a 3-year grant. The federal government removed this line out of their budget, and so kind of caught us a little by surprise when we had planned an arc of activities over 5 years, and really forced a lot of quick work in the 3rd year to close things out. And interestingly, even though that ended, the next thing that CDC did was bring back REACH grants and what they called pitch grants, and those were partnerships, something in community health, for community health. And they were essentially what we called CTG, community transformation grants, just broken up differently or worded differently. The work plan, because I worked on a proposal for one, the work plans were the same, a lot of the topic areas were the same. So it was this really confusing time to have said, well, we're doing this, and it ended, and then there's funding available to basically do this in different ways. But it was designed to combat chronic illness using policy systems and environmental change strategies at the local level. And so California received the most amount of funding as a whole, because what they were doing is they funded large counties. So Los Angeles had its own CTG grant. San Diego County had it, Los Angeles County, so not just the city of LA. San Diego County had its own CTG grant. Fresno County had its own CTG grant. San Francisco had its own CTG grant. And I think those are the big ones in the state. And then they said, what we're awarding PHI to do is this rest of state. It was called a rest of state award. So basically all the counties in the state whose populations were under 500,000 were included in this rest of state award, because oftentimes CDC will put in these population thresholds. And so the small counties never are eligible on their own to get these monies. And PHI, before I even came on board, had, and in conjunction with CDPH, who, by the way, was the original, was going to be the original applicant. And somewhere near the 12th hour, I understand, they said to turn to PHI and said, we can't get this done here. But there were surveys out to the small counties to really start assessing readiness to be involved in this. And out of that, 12 local health departments were selected that their populations represented, I think, somewhere around 60% of the total population of those 42 counties. And it was one of those reminders that, you know, when we think of California, we think of LA and San Francisco, but so much of our state is actually rural and small, and that smaller counties, smaller populations. And so that was a big push of this award. We had the option to do, there were 4 strategic areas to do work in, and you did, one of them was optional, but I think the agreement was for all of the grantees in California, they were going to do all 4. And so we did work under the banner of healthy eating, around healthy and safe physical environments, around tobacco-free living, and clinical and community preventative services. And people could figure out what that meant under that banner, what they did. But in California, we all said we would all try to address all 4 of those. So we had 12 local health departments, each of which were addressing 4 strategic areas. So this became our handy little reminder for ourselves. The yellowish counties were the 12 that we funded. So we were working with counties. So Ron has the Siskiyou, so the Oregon border down to Imperial at the Mexico border, and spattering in between. Some more rural than others. Solano County, I think, was probably our most urban and our largest. And Madera might have been our, Siskiyou is geographically large, but not a large population. So between Madera and Siskiyou, I think they might have had the smallest population, somewhere in that 50,000 people, if I remember correctly. And also, when we're talking in the Central Valley, so we had counties that might have had majority of Latino populations, and then you get up in places like Siskiyou that were really more like frontier counties. And our challenge was, we had decided for healthy beverages, it was sugar-sweetened beverages, so increasing access to healthier beverages, reducing access to sugar-sweetened beverages. We chose safe routes to school, which kind of modified once you start talking to people in some of these counties, and they're like, well, our issue is a trail system, so how do we frame this that works for each one of them? We did smoke-free multi-unit housing, which in hindsight may not have been the best choice. I was not the one that made the choice. But when you get to some of these small counties, they don't have a lot of apartment complexes, not that are large. So trying to get certain numbers when a multi-unit housing for them was 5 apartments in a building versus, you know, what we see going up around us. And then we use chronic disease self-management program for the clinical community linkages. And we used the Stanford CDSMP model, which is an evidence-based model. And then the blue are all the others. And we were fortunate after 1 year, we did have some unspent funds, and we were able to convince CDC to let us do some small mini grants to counties that were not part of our 12. So they were able to get around $25,000. We did another 10 or so grants to some of the small other counties. So, you know, we, as part of this process of how do we, there was a moment of how do we handle 4 different topics, 12 different places, different staff in each. We had an evaluation team, so Lorene and Ron and Suzanne and others were working on the nutrition side, and then we had Ian and Alan. What's they're like Kaiser now officially or something? Yeah.
Center for Community
Health, yeah. So they took the lead on the clinical community linkages. So we wanted to do evaluation. We actually proposed another evaluation, and CDC didn't want that, but these were the 2 that CDC greenlit. And so a lot of moving pieces. We wanted to have a name that kind of at least identified folks as being part of the whole. And that's where CA4Health came as the name for the project. And we came up with a little logo and the tagline, healthy places, healthier lives. And that, you know, we want to emphasize that for us, it was this vision around rural and small communities and their ability to live in healthier places. So we were really the backbone, and sometimes puppet master, and sometimes enforcer, and sometimes wizard, and sometimes, but we were relying on folks locally to implement. We also had a team of TA providers that some were CDPH folks, like from the Tobacco Control Program and the Safe Routes to School program. And then we had another group that used to be there's the PHI project that was in CDPH, but Project Lean. So there were a lot of touch points and these additional moving pieces. But we wanted to make sure that the 12 counties had the tools and resources to actually do this. Because for the most part, for all of them, this was completely new. We had counties that had never received any funding of this nature before. Shasta, I think, was one of the only counties that had an initiative, and they were, when you think of some of the more rural counties, they were always like the star. I've learned later that it creates tension around neighboring counties.
And keep in mind too that PSE was a new thing for SNAP Ed at this time.
Yeah.
So now people are with it, but in 2011.
Yeah. Did not get it.
Not.
A lot of work.
No. And a lot of resistance. And not even if the staff got it, what we also started to learn is many of these counties are quite conservative or libertarian in their approach. And so to get their boards of supervisors to approve the budgets and the work plans, and they're like, we can't say policy, but we mean policy, wink, wink. And some actually would say, well, it doesn't say policy, so I'm not doing policy. And it was like, I thought we all understood. But we really set out to push that as much as possible. How much can we do that is policy systems, environmental change, and not more behavior, health education? That could be a component of it, but we really wanted to be pushing for environmental and policy change. Big P, small p, whatever that looked like. We then had to work with each site to figure out, if you're in Calaveras, what does that mean for you? Which is not going to be the same as being in Merced. And one of the things that I think wound up being really appreciated through this process is we allowed them to customize things based on their communities. They still had to do healthy beverage work, but it wasn't that everybody had to do, we're going to work with our vending machine supplier, to change the contract, to change, that could work in one county and another county may have had another approach. Or Tuolumne said, we want to connect this trail system from the residential neighborhood. It's not finished to get all the way to high schools. So theirs was a safe routes to trails kind of approach. And Calaveras was, we don't have sidewalks, so we need to figure out how to make it safe, and maybe we infuse this into a mobility plan. So we couldn't have a one-size-fits-all approach, but they all had to work basically in the same topics. And then our hope was that having this type of initiative with so many different sites, a concentration of assistance and specific funds, that we could be developing this kind of evidence base of what might work in rural and smaller communities. How can we make that part of the conversation when there are webinars? It's not just, here's what LA did, but that they feel like they have something that they can share and people find validity in it. And I honestly believe that we did things that I don't think a lot of the other CTG grantees did or were able to do. And some of that is because of the small nature of the communities. Also, I think because of the assistance we had, and sometimes they didn't like it, but we were writing them a little, like people were we'd get on CDC calls and people were celebrating. We made a banner and we put it up and we're like, these people changed their master plan to infuse health elements throughout the county. Like, those were the things we were pushing for, and other places, it was different. So we were really proud of that. Even though we ended early, 2 years early, we still did. So we did put together this report at the end. I think you all probably have copies on your shelf that has a page for each of the counties where they talked a little bit about what this experience meant for them, but also, and we wanted to be able to celebrate the success that did occur even within those 5 years. And so across, like, each county would identify, this is the number of people or the reach. Like, a lot of these things you can't count people, but we would say, okay, if you're going to make this change and put in a water station at the fairgrounds that didn't used to have water station, how many people actually attend come to the fairgrounds? So we started approximating what would that mean in terms of reach. And so we added up all their work plans to say, this is what, as a program, the goal is in the left-hand column, and then we added up based on people's final reports where we landed. And you can see that in year 3, we had done some tremendous work in that regard. And the biggest one for challenge was around smoke-free multi-unit housing. And for that would be, so one, not a lot of multi-unit housing, but also this idea of, that really started to get into that conservative libertarian where people started putting their foot down a bit. We were actually in a meeting with one of the boards of supervisors in a county talking about the grant, and the minute he heard, and he was a smoker, we didn't know that till later, and we saw him outside, but the minute he heard that, smoke-free multi-unit housing, he was like, we're not doing that. Like, we're not going to kick people out of their houses, because it's like, that's not what this is. And he wanted them to take the lightest touch approach. Like, if they went to any policy, it'd always be creating a smoking site at an apartment complex. And so we couldn't challenge that on a regular basis. And we even had counties that the board didn't always want to even sign their contract. So if you're a small county and you're getting $250,000, which is basically about what every county got a year, which for some of them is a huge infusion of money, like Siskiyou said, they were like, this is a federal conspiracy to convert us to nanny state. And then they said, but we're broke, so we'll take the money. So there was not a lot of help for the staff in that regard, but people got really creative, and we tried to be as supportive as we could in that creativity to see what that looks like in these different places.
That's why I called her a wizard.
And then I figured I couldn't do this without mentioning evaluation. As I said, we did evaluate 2 areas, the healthy beverages work and the clinical community linkages. And for the top line summary from your evaluation report, do you all know about food beams? And I couldn't really explain it to you exactly, but
it was developed by Sally Yoshida at Samuel as a tool to assess beverage access and types of beverages available.
So they all got tablets, and it was electronic, and it would upload, and they would go to, whether it was a meeting or a vending machine or whatever, and look at what was there, and then go back. And even in that short period, and I know that it was a mad rush at times, and people going, what, you mean we have to go back? Or we were supposed to take this at baseline? You know, seeing that there were Project Lean, which was, they were a PHA project that worked very closely with CDPH, had beverage standards, and we were trying to get people to adhere as close to 100% to that as possible, but recognizing that for many that was not possible. But that in that time, seeing this shift, a positive shift in the sites in terms of starting to what they were making available look more like what we were recommending, was being recommended in those standards, and then that the sugar content had declined per serving.
And just so you guys can put this into historical perspective, we thought this was pretty impressive, given that all of the counties thought they had 4 years of implementation, and it got cut to like 2, really. And so many of them had plans, but they hadn't had time to really execute them. And you know from doing all your PSE work that these things take time. This is not the kind of thing you just go, okay, I'm going to train you to do this training or this education. This is relationships and time. Yeah. And so we were disappointed that we didn't get to do the full 5 years, but I thought we felt like, considering.
Well, it helped that you had measurement, because when you go out and then they know you're coming out again, it tends to accelerate the work. So I think we had a role to play in that movement when we did a remeasure.
A nice unintended consequence.
Yes. And actually I'll always remember for Calaveras County, the coordinator there, she'd been with the county for many years, and she had told me that her plan was after the 5 years of this grant, she was going to retire. So it kind of forced her hand earlier than she had planned, but that when news came down that it was ending, she just said, I'm going to stop tiptoeing around things, and I'm just going to push, I'm going to ask for the things that I want. And not ask, and she's like, and doors just started opening up for me. And she's like, if I had started at that place instead of, can I, should I, maybe, let me, you know, but so some people just said, I have nothing to lose at this point, just really pushed. The other area that I think that our grant wound up being really advanced in this regard. There was a moment where CDC wanted us to connect to TA providers, and they had us talk to whoever their TA provider for that was, and what we were doing just went over their head. It's kind of like, yeah, we don't need your help. But this was something really different for folks to say, as health departments, we need you to make some relationships with clinical providers and start trying to do this process of getting people with chronic illnesses into this evidence-based program that's a multi-session program. And we trained staff in the health departments were trained. People then started developing relationships with promotora networks, trying to find ways to expand usage of community health workers. And how do we use that model to affect larger groups of people in a way that has been shown to make a real difference? When and we got to a place where, alongside this work, like we met with one of the health plans that was serving some of the rural communities to say, would you take this on? Like, we were trying to find sustainability plans. And they recognized that their process was to do one-on-one. And we're like, but we're getting 25, 30 people at once that are going through this together, and they're reinforcing it together. And they, at that moment, were not bold enough to take that step. But I understand they've now moved to a model where they're really embracing community health workers. And so, and our TA provider on that, Pam, started convening folks around the state to say, how do we at the state level start to codify this working class? How do we make some consistent accreditation standards? So if you go to City College or Solano State and you say, I got a certificate as a community health worker, that people understand that there's some core knowledge underneath that, instead of we're teaching whatever we teach and we teach. All that got cut short, but we had a big convening with people from the state. We had other leaders in that area and started to develop what would be core elements. And I think that is continuing to develop in different ways. But we saw a real opportunity to make the work that community health workers do reimbursable. And not just that they have to be volunteer workers. But what Ian and Alan did wound up being less of evaluating actually what folks did, and more of saying, we see these four models emerging, because not everybody's looked the same, and really trying to outline what that could look like. So that was CTG, and I thought I'd just throw up these quotes from some of the participants, you know, or some of the counties, the health department staff. We did really encourage them to partner with community groups. We really tried to get them to carve out some portion of their budget, so it wasn't just within the health department, and most of them were successful in that. But that they said it changed for them their interactions with their boards of supervisors. It changed for them interactions with new partners. Like I said, some of them had never talked to the clinics in their community, and now they were scared to at first, but then they were able to develop this relationship. And their elected officials in Tuolumne County, they didn't know they had kind of come at the general plan language change kind of backwards, but they found themselves in that place, and they were being gentle, and they were like, could, might, and they said when it got down to it, the board of supervisors were saying, no, we want this to say that we shall. And they started strengthening the language and saying, we want our county to be seen as this other place that's providing these health opportunities. And even Siskiyou, with all of their challenges, at the end, they start realizing, because it's a beautiful county, and they said, why isn't this a destination for people who like to do outdoor activities? And so the Bike Coalition was like, we want to take on your Safe Routes work and continue it after the grant, because we'd like to now make Siskiyou this place for people to come and maybe bring in some more tourism dollars. And so, you know, as sad as we were, we did see real growth in a lot of these counties' health departments that had not done this work. I think one of the rising stars was Merced County, and I was, I guess it's kind of like seeing your kid grow up and go off to do something good. That when the new CDC funding came out, we said, is this something you want to try to do as a group again? And they said, you know what, we think that we're ready to apply on our own. And they did, and they got it. And then after, they got a lot of other funding. And so, they said, we know how to fill out this paperwork. We understand these work plans now. And Tulare County applied as well. They didn't get it, and Madera County applied as well. So these counties that originally were saying, we don't know how to do these CDC applications, the staff at least felt like we understand the forms, we understand the language, we understand the concepts, and we're going to try to go for this ourselves. And to me, that's a huge win in that capacity building realm that was not a formal requirement of the grant, but I think one of those other unintended consequences, positive. Any questions? I'm running out of time. I spent more time on it than I thought I would. So CA4Health ends, we get an extension, evaluation's able to finish writing their report, we get this report. Basically, my whole team has found other jobs. Everybody's gone, but me and Christina, who's the admin coordinator. And then the new announcement comes out for the pitch and reach, and California once again got the most amount of money and the highest number of awards. When CTG was occurring, there was a shadow project that the California Endowment was funding because they said, there's all these people getting the CDC money, how do we connect them? But then when the funding was ending, that whole idea kind of went out the window. But they said, hey, let's have another conversation now that we see that there's going to be this continued funding. And where things started going was CA4Health seems to make sense as a name because it's still California, it's still health. As you can see, if you look at we did little changes to the logo to kind of signal that it is new. We didn't make things as dark, we made them a little bit lighter. But that where we landed in these conversations with the endowment was that there was, how many people know of California Convergence or knew of California Convergence? And so California Convergence had been in existence for over 10 years, working around communities and advocacy, and the endowment said, we want this to be part of this. We want to take essentially sort of the historical connections and knowledge from CTG, California Convergence, and what it was called Partnership for Healthy California, which is the one that was connecting the CTG grants, and kind of put them in a blender and say, can we still do something that provides a space to connect folks that are doing prevention work in California? Is there still a value in that? There was, for the Partnership for Healthy California, they had done some surveys and interviews of CTG awardees, and the report that came out, there were two findings: that there was interested in continuing to bring stakeholders together, and because they wanted to build capacity. They wanted to increase the scale and impact of their work, and they wanted opportunities to build capacity. So based off of that, the endowment said, okay, we will fund this statewide, of course, we were like, learning communities, community practice, network, what is it? And we landed with community practice, and it's not like strictly your traditional community practice, but that's the language that we chose in 2015. So myself, Christina, who was part of CTG, at that time, California Convergence was basically down to one staff person. Lisa Hershey, who was the director, had moved on. So Cristania De Leon, who is doing that work, and Genoveva Islas, who was doing the Partnership for Healthy California, we became the new team for CA4Health. And we saw this and started pitching it as, you know, so often when you have these networks or groupings, they're very geographically focused. We're like, this is an opportunity to connect statewide and not just in your geography, but also in your geography. So we're, again, trying to do these layers of regional and statewide, and nothing's ever simple. I never get handed anything simple. And so who's out there working on prevention and equity issues, and how can we provide space for them to come together and learn and share? We also saw that because of what Convergence was doing around advocacy, that we made that a core component of what we do, and a lot of the other networks, they shy away from advocacy action. And as we were kind of rolling this out, you know, we understood that typically these types of initiatives have a specific topical focus. You know, it's the obesity or diabetes collaborative or this collaborative. This is like chronic disease and equity. That's anywhere that you could go. And it wasn't specifically for like bar highs, for health departments. There's also Public Health Alliance of Southern California that is focused on health departments. So we also didn't have a specific audience that needed to be at the table. So what we quickly started to learn is there are people for whom that strikes them as an amazing opportunity, and there are people for whom it's like, I don't understand it. I don't know where I fit in. Like we were trying to say, no silos. And you know, you start realizing, oh, I guess I'm used to silence.
It's a little comforting to have edges.
Yeah, yeah, people want some boundaries, and you know, and so, so this was just kind of shows the core reasons why the endowment wanted to establish this new CA4Health, but back to, you know, not just CTG, but Partnership for something health, PPH, probably prevention in there, other CDC initiatives. There's all this resource and knowledge that's been gathered in California. And how are we, these initiatives come and go, and then the knowledge kind of goes with it, that can we be talking not just to, if our work is nutrition, can we also be talking to, so it's great when you say you're talking about housing insecurity, even though somebody might say, why are you guys talking about housing insecurity? But we kind of intuitively know that there are these connections, but we don't go there often in our work. And that we want to keep expanding relationships with people, that if you know what somebody else is doing and then you learn how they did something, and you know, all that peer networking, and then can that help deepen or maximize the impact? And that was really sort of the initial vision from the endowment of, this is why we see that this could have a role. And so as a team, as we start figuring out, well, what does that mean and what does that look like? And it's been a journey since then, but we knew sort of at the heart of it, this idea of collaboration and networking being powerful, but not easy to do when it's not like, I have no illusions about with CTG, those were my paid friends. You know, they were all receiving money. They all had to show up when I told them to show up. And this is not that. It's like people have to take their own time or interest or say it's worth it to the work that they do or their organization to participate. But that, you know, also we really brought into, wanted to move equity front and center as much as possible. That you know, we've been kind of since this started that in these moments, where the current events are forcing us to kind of confront things a little more head on than we may have in the past. And so how do we bring that into our work? And then how do we also acknowledge that if we just do business as usual, we're not necessarily going to move the dial the way we need to move it. You know, and what I was sharing with people is that for me, we all, you know, now in public health, everybody learns about social determinants of health. And if we're really saying that that's what we're about and that's how we're doing our work, we do need to work together differently to change those environmental settings. So this is kind of our little statement about who we are, being inclusive. So whether you're a person who lives in a community or a CBO or a health department, whatever, everybody's welcome at the table. And that, you know, our role is still sort of that backbone role to try to create platforms for intersectional thought, dialogue, and action, because again, it's that sense of believing in that collaboration is the way forward for us to make lasting impact. And also because of the inclusion of California Convergence and to differentiate ourselves from a lot of the other groups that are existing in the state that may be health department focused, we have a little bit more of a focus on including grassroots and community-based allies, you know, because they're often at the forefront of these social movements, but they're not at the table in our professional spaces in the same way. And so that allows us to try to continue to really operationalize and stay connected to this essence of equity. And equity is sometimes messy, and it often doesn't fit within what we learned in school, but it's impacting the communities that we're working for. It's impacting the policies that need to get passed. And can we be a space? So we're like, can we be better about how we share our expertise with partners? Can we not let our workplaces, silos, and funding objectives keep our minds and actions closed off from other things? Can we be unifying our voices, supporting each other for and against policies that can alter landscapes and environment? I mean, if you're pushing a housing policy and we all understand that it's connected to all these other things, shouldn't we all be signing on to that, even if our role is in education? And that can we, for CA4Health, create spaces or convenings where we're not shying away from root causes or those hot button issues like racism or immigration? Can we be bringing those assertively to the table to be part of the conversation and not have them kind of be behind the scenes? And this has been the endowment hasn't, they kind of shaped the concept, and then this has been, I think, the part of our team. And now essentially our team is myself, Chrisania, and Christina, so we're a small team to be trying to work statewide. But so we've been out there trying, and we've been evolving. We've been saying, let's try this. The first, the endowment said we want you to do regional meetings. We did some regional meetings. It's hard to sustain regional meetings when you don't have people in every region in the state, but we were traveling up and down the state. But we kind of grouped our work into 5 pillars: convening, organizing, promoting, advocacy, and building capacity and leadership. So we just kind of call it COPAL. So our bread and butter really is around convenings. And so we've done in-person regional convenings. We created this framing around, we call it people, power, change. And it was something that Convergence had done a couple years ago when APHA was at New Orleans, where recognizing that APHA is expensive. And there are a lot of community groups doing work that cannot afford to go to APHA, so they did a one-day convening during APHA where it was open to the public and free. And so we just did that as well in San Diego. And we talked to San Diego partners to see what did they want it to be on, and the focus there was on immigration and environmental racism. And so bringing in people to just, you know, if you want to come and have that conversation, let's have that conversation. We did the series last year where it was regional convenings. The focus was around food justice and poverty reduction. So again, going up a level and like, let's not just have the nutrition conversation, let's also talk about land and agriculture and food security, and, you know, because it's all part of it, but it's often not what people are funded to do. And so we met in Southern California, Central California, and the far north, had local folks share their stories, had breakout tables for people to talk, and then poverty reduction, so talking about education and employment, and trying to say, let's bring all these things in the room. And people say, well, I don't work on that. But just having dialogue, they say, really have an opinion, and they understand how it connects to their work. And so does it help people bring that back? And then we did an advocacy 101, because the end was to do a day of action similar to an ACT Day with those folks. And so that was like people power change. They're building that capacity, and then they're getting to talk to elected officials. This last year we started doing these virtual meetups. So just a Zoom video call, and learning that people do not want to be on video. They would rather do whatever, not be seen. But, you know, we transitioned into a membership base last October. So there were members that said they were interested in talking on different topics. So we had folks sharing their work around food issues. We did one as policy update, so bringing in partners to talk about what's the policy landscape in the state, as well as we may have touched on federal. And then we've done one on housing justice, so really looking at CDFIs, and I'm now just blanking on what that means. But so organizing is, can we be a place, a hub for folks? So we do have this membership now. We've got over 100 individuals and organizations, and with the organizations, it's like 1,000 people, over 1,000 people that are kind of connected to CA4Health. That Policy Link has put on 2 equity summits since we've been in existence, and we have been able to bring delegations to both. So some of that was providing scholarships and helping people get to, when it was in LA, it was a lot easier, of course. Chicago was harder, but we still, you know, we're able to say, we'll pay for your registration and we'll pay for people to share a hotel room, but they have to get themselves there. We've recently released our own sort of guiding principles for health equity and justice, that we want that to be, this is how CA4Health will approach certain things. We're going to support something. These are the lens by which we will look through it. It's on our website. If anybody, you know, wants to take a look, and some people have found it really helpful and are looking at adapting it themselves, and we work with members to put that together. Some of us sit, so like the California Alliance for Prevention funding, I think, Lorraine, were you able to go to the Wellness Trust? So like yeah, so I made sure you got that email. So that's me.
We wondered how we got invited.
Yeah, me. So I try, like when I see things and I know things and I know of people, it's like, who would be good to know about this? So I participate on that on behalf of CA4Health, and I do try to bring, it is heavily government groups represented, and I try to bring some other perspectives. Like when they were first coming up with the financial breakdown, it was like, why is all of this going to health departments? The California Food and Farming Network, Christania participates in that. And then this other Committee for California's Health, which is TCE, does equity awards for health departments, so I participate in that as well, trying to get them to include some community groups. I'm losing that battle. We do a newsletter. Right now it's every other month. We're looking to pull stories from the field to share what others are doing in the state, not as our stories, but again, that how do we help people see what else is happening. And at the end of CTG, some videos were, stories were collected from awardees around the state. And we were able to finalize these prevention videos. And so there's one on healthy eating and one on physical activity and one on clinical community linkages, and you have snippets of interviews from people who were CTG awardees, and we try to create it in a way that if people needed materials to have that conversation about prevention, that those are resources that are available. The advocacy, Kristania has been part of planning and ACT Day since she was part of Convergence, and is really one of the leads at the table at this point. And last year, where Phoebe was there, we were really excited that it's traditionally been nutrition, physical activity, and the year before we had said, why are we limiting this? Like, there's so much happening right now. We need to, and last year it was broadened. The platform for the first time was broadened, and having people talk about housing issues or criminal justice, as well as physical activity and nutrition. And so, again, trying to model that social determinants, we can't just keep separating ourselves. We do sign on to letters. We do push information out. Our newsletter will have policy updates, as well as I think we'll be doing another video call to talk about the new governor and what are some of the priorities and the opportunities for people to participate. And I think it's still our hope that people see each other as a broad community of these are all good things for the communities, and we need to be supporting them even if it's not our topic issue. And we do a survey of our members to find out where are people's areas of interest. And then for building leadership and capacity, we do see like the issue around advocacy. Kristania does a great job of helping people. We created sheets on how to do, tip sheets on how to do recess visits and how to basically do an act at home. And but you know, we do have a webinar we recorded. We had done this Connecting the Capital series on alternative financing, and we did a series on marijuana and our health last year. And what I was hearing and seeing was conversations that were really different if you were at a health department and how they talked about marijuana versus the community, and that people just had never really invested the time to understand all the complexities of what that is. And we're then making policy or coming to conclusions and wanting to take actions based on of lacking or misinformation. And so we did one part that brought in Institute of Medicine has done a huge report, somebody from there, and the guy from Colorado to talk about what they're finding in their data. Then we did a second one on the history and criminalization in communities so that people understand that component, and then another session that was more on sort of policy creation. And that was just something that we really wanted to do, and so we did it. And then we've done a webinar on health and housing, intersectional health and housing. And then we do try to find if there are conferences like the Equity Summit or even APHA. We did a scholarship like a storytelling competition to offer scholarships for up to 2 people. So we always try to look at our resources, and even though they're not a lot, to say how are we sharing and helping people get in the door to do things so that they can build their leadership, or how can we be bringing things to people that help them. And so in 2019, along that theme is we want to bring some of the innovation space skills to folks. And so we're going to be trying to devise a couple of workshops where people may bring their issue that they're trying to overcome. And, you know, and if it's a option to sit and learn about alternative financing or participatory budgeting or design thinking or whatever, that there's an opportunity for people to be there with an expert to work through. So it's a workshop, not a sit and listen. It's a workshop. We're continuing to support Enact Day. It's April 30th. If you don't have it on your calendar, Sacramento.
How many people here are going? I know, Ron, you're going.
I went last year.
Yeah. Yeah.
Who else? Is anybody else going?
We'll see.
Oh.
It's free.
People are not.
Wow.
If we happen to be in town.
I know
to do
Ken's
something
going.
else.
Ken and Ron are going.
Yeah, cool. Well, we'll see you there. And that the topics that came up in the survey for us to focus on are food justice, housing justice, transportation, mobility justice, criminal justice, immigration, and economic justice. All huge. No guarantee there'll be bills related to any of those that will go anywhere, but we also
on a few things.
no. but you know, we're like, so what if this other thing comes up and we know that it's connected to immigration, but it's not, you know, there's a lot that California's already passed that other states are still working on. So we're trying to be attuned to all that, but we're going to pick like 2 or 3 bills and actually try to get more people engaged in campaigning related to that. And we want to do a better job of trying to promote stories from the field. We always ask people for stories. Nobody ever sends. So we'll contact people and interview them and then write up the story. But it's something we're trying to do more of and do better. So that's
Wow.
CA4Health.
Question, who would have known? From 12 counties and 4 topics to criminal justice, all the J words.
Yeah. Yeah, we figured using justice was important because we also want to bring some of those actors more closer into the public health space. I mean, we're getting public health back to its roots, which is justice work. So yeah, the future we don't know.
Questions? There's 2.
Well, I mean, maybe this is too big a question, but I'm wondering, you know, looking at us sitting here as researchers and evaluators, like what should we be thinking about equity and justice that doesn't sort of automatically come into, like I'm thinking, you know, it's not openly, expressly part of everything we do, but it should be part of everything we do. What are your thoughts?
Some of it is recognizing that, you know, and then asking certain questions. And then it may be a matter of it may not be your role or your space to be the actor, but you have data and information that the actors need, credible data and information. So are there partners that you should be trying to connect to say, we're doing this work, and so we're going to have this data if it's going to be useful to you if you're out pushing something. And that's, you know, when we talk about health departments, the minute you say advocacy, they're like, get away. And we're like, we're not lobbying. We're not saying lobbying. We're saying that a lot of them can't even go close. But that's some of the same conversation of that you have information and data. And is there a way for you to package it or ask new questions? Are there people that might give you a new question that you're like, wow, we never thought about that, but that could really inform the conversations or the actions. So that I think is a way to be in that space.
Yeah, that's great, and I love that idea. But even, you know, what if we, you know, again, too responsible for our time, but like every time we post an article, we also have a sort of public accessible fact sheet. You know,
We've been trying to do
yeah,
that with some of our work.
Yeah, I know we do it for sometimes, and yeah, but
Yeah,
you know,
not
like,
always.
but it's like, you know, because you need the evidence, the journal article, that information is really accessible. So you don't need to read the whole journal.
I started in public health doing research, so I get it. And, you know, and it's like, how do we take the research, and because it's like policy, program, practice, and but is it within our own sphere, or can we also be bringing other people in, or at least making them aware of what's there, or how you think about what you found, what's its purpose or usefulness beyond informing the field, but also changing a system or a policy based on what you found.
Next question. Going back to your slide where you had the goal versus the actual for your reach. When you were setting your goals, I'm curious about the chronic disease self-management. Were you looking at your clinical patient load when you were setting that?
It was, that was the number of people who then had access to these classes.
I see, okay.
So if you only trained one person who could run the CDS&P class, your reach is limited. But if, like, people start working with the area agency on aging and training their staff, so then it became part of what they offered. So then, and then people start referring to them. So it wasn't always easy figuring out reach, but it was around how many people could now have access to these services that would not have had it before.
That's how you calculate your actual, right? Is that how you also? Oh, okay.
It was the 5-year reach goal was always people looking at, this is what we think, and they could adjust it annually and say we were totally wrong. There's only 10 people that live here, and then we may say, well, you need to find your place. But yeah, it's and CDC would do like their next round, let's say 75%. It needs to reach 75% of the intended population. And so that's where we would start saying, let's look at your data and what's 75% or that we think we could get.
I'm intrigued by your collective impact backbone type approach. And we have something called the National Drinking Water Alliance here at MPI that's using that same kind of be the hub to connect to all these diverging partners that aren't used to talking to each other and bring them around a cause. I would love to know how do you get sustained funding for that?
If I figure it out, I'll let you know.
Okay.
We've been really fortunate that essentially our sole funder for these last 4 years has been the California Endowment. But like the first year it was 1 year, and the second year was 1 year. And then George Flores was our program officer, and he did 2 years. He's now retired.
Right.
Then we were moved to Richard Figueroa, who just joined the Newsom administration. So right now we don't have a program officer, so we're like, we don't even know who to talk to at the endowment to make our pitch. Yeah. And what I've been hearing just in different places is this idea of funding a coalition or a network is no longer what funders are doing. And then like Kresge, PHI brought Kresge into a principal investigator program director meeting to talk about their new strategic plan, and people asked, you know, they said, what we will fund if your group says, here's an activity that we want to enact. We'll fund that, but nowhere in there should there be money for somebody to coordinate that group. And it's going backwards. It's going backwards because there was a moment in time where they all were really interested in funding networks. They saw the value of it. And now it's like this belief that everybody has bought on and is in kind or out of their existing budget is going to say part of your time is to do X. And my experience is that while that happens here and there, that for something to be done on a regular basis with notes and move something forward, it takes time. The amount of time it takes us to get somebody on the phone to actually speak at something is not just somebody's, you know, I just shot an email off and I got somebody to do this. And so I don't know, like they want to see I think they want to see tangible results or outcomes out of it. And so one of the things that we struggle with is, do we actually try to apply for a project as CA4Health that allows us to kind of do, like, find some partners in CA4Health that want to do something collectively. So kind of going back to CTG, can we be the connector between a place in the north and a place in the valley and a place in Southern California, that maybe that's enticing to a funder to say, wow, we'll actually have something happening in multiple places in the state and be part of that implementation, but that also helps us maintain some of these other activities. We're constantly trying to figure that out.
It's just so frustrating because
Yeah.
by the time you get funded long enough to do something, you're just going, then the funder is off doing something else.
Yeah.
You are just getting your wheels
Yeah.
like oiled and all
Yeah.
the parts together, and you
Yeah.
know, and then they say, but you didn't show us impact. But wait, but
we're about to. Yeah, I think that I've, like I said, it's just been random places that your ears perk up when somebody who's been doing network work for years saying, well, our budget's changing because they're no longer going to fund us to bring people together, or Kresge saying, we won't fund any staff time to be the convener. And I guess you either fudge it and you hide it in there and it does fund that person's time, but not really. But for them to not explicitly say that they want to fund networks of that kind is hard.
Yeah.
So
I'm getting to the age where I just don't think it happens by itself in a big way, like you said. It's all coincidental, and so sometimes you can point to a few examples, but most of the time it's not going to happen unless there's somebody dedicated to doing it.
Yeah. So we don't know. Honestly, we have funding until about October, and we have no idea. I mean, we're going to try different things and look at fee-for-service opportunities. Like, how can we get money to do something that allows us to keep doing this other thing? I mean, those are all going to be part of our conversation.
Could be fee-for-service, perhaps.
Yeah, or the skills workshops.
Yeah.
I mean, that's one of the things that, the things that we've heard from people about, that I feel like I heard, like doing CTG and stuff, like, what they really liked having a coach. And essentially, our TA providers were acting as a coach. It kept them moving forward. They didn't get sucked into everything else. Or if they did, they knew somebody was going to call, or they're going to have to write a report or something. And and it kept them focused and moving forward. Or I feel like at this point, you go to conferences and somebody talks about a neat thing, or you have a webinar and you're like, wow, that was neat, but I have no idea how to do it. Or I got this toolkit sitting on my shelf, and I don't really have the time to go back through it. But people, like, if you have people captured, how do you utilize that space and time to the highest capacity so that they're actually, we started bringing in postcards to, it's like, write a letter to your elected official while you're here, because once you go home, the odds of you doing this is probably slim. We've got laptops up. Type in, find out who your person is, sign on to this letter, do something while you're in this space, because once people get back into their day-to-day routine, if we think of ourselves, just don't.
I know, I have yellow stickies.
Yeah.
They don't always get done.
So
it's hard.
Yeah,
going.
And
trying.
Do you have a listserv or something? So
we do.
That would be, if you could add, who should we add? Add Dan.
I think are you a member, Phoebe? Did you?
I haven't been getting anything.
It'd be good for a few of us too, because I think some of your webinars too would be.
The easiest thing for me is if you
go on our website. Okay, so why don't all of us who want to be connected?
Yeah, you can just sign up and be able to get newsletters and stuff. You could also sign up to be a member if that was of interest. There's no fee, and even though some folks have said you should charge something, and then I think about it, when you think about who we're trying to bring to the table, they're not corporate entities who are going to say, here's $12,000 for my membership or whatever, and you can sustain staffing on that. I'm like, it might pay for the web hosting costs, and so it's just, it's free. And we do try to say there are certain perks. So like the scholarships, we only make available to members. So we may tell everybody and then say, but in order for you to apply, if we get an application and we see that you're not a member, we're not going to read your application. But there's either way.
Okay, that's great.
You can also
Thank
send me
you.
an email and say, put us on our.
I know, I can go to your website. I can manage that.
Yeah. But I have your email, so like I think of people
know.
and even I think at that meeting somebody from the Alameda County Community Food Bank was there, and that was you know, it's like, oh, they should be like the people that aren't part of the conversation for things like the Wellness Trust, but should know that people are trying to do this, and it's going to be resources for the type of work that you're trying to do if it all happens. So. You're welcome. Sorry, went over.
No, it's totally fine.
Great, it's really interesting. Thank you so much. It's so cool to see it going.
Yeah.
So gratifying.
It lives